Hello, and welcome to JAMA Health Forum Conversations. I'm Dr. Sandro Galea. I serve as Dean of the School of Public Health at Washington University in St. Louis, also as Editor-in-Chief of JAMA Health Forum. JAMA Health Forum is a peer-reviewed open-access online journal focusing on health policy, healthcare systems, and population health, one of 12 specialty journals in the JAMA network. Today, we're going to talk about primary care. Primary care is central to how we experience health. We see doctors for regular checkups, get the help of primary care when we are sick, and spend a sometimes inordinate amount of time navigating the healthcare system with the help of primary care providers. The quality of these experiences, in part, shapes the quality of our health. While in the United States, the primary care system has some of the best providers in the world, we have long struggled with an underinvestment in primary care compared to how much we spend on specialty care. Many health systems have struggled to provide adequate primary care. New technologies like telemedicine and AI have the potential to both improve and disrupt the systems that deliver care. The prospect of Medicaid cuts under the new administration further threatens primary care. Addressing these challenges and embracing the opportunities of the moment has the potential to improve primary care in the U.S. Here to discuss how we can do this is Dr. Bob Phillips, Executive Director of the American Board of Family Medicine. Dr. Phillips also serves as Director of the Board's Center for Professionalism and Value in Healthcare, which works to improve healthcare by creating opportunities for health professionals, policymakers, and payers to support better outcomes. He practices in a community-based residency program in Fairfax, Virginia, and is a professor of family medicine at Georgetown University and Virginia Commonwealth University. I'm delighted to have Dr. Phillips with us today. Bob, welcome.
Thank you so much, Sandro. It's good to be with you.
So let's start with the evolving role of primary care. So how do you see primary care in this country evolving in the next decade? What are some of the central trends that you see shaping primary care?
Well, let me start by saying I'm optimistic, but I do think we're at an inflection point for primary care. To your earlier point, it has been neglected in the United States. It is where most people have their healthcare relationships. It's where more than a third of all healthcare visits happen, but it is, in most places, less than 5% of total healthcare spend. And it's that routine starvation of this function and the increase of burden on primary care, particularly with the onboarding of electronic health records, with value-based payment models. Those two things, the starvation and the burden, have really contributed to an erosion of the workforce and a problem with access that has made access the priority over relationship. And relationship is really the secret sauce of primary care. The ability to have the trusted relationships that help people change behavior over time, that help people decide to take care of their health better. And so the inflection point we're in is, are we going to make those investments? Are we going to reduce the burden to improve the capacity of primary care to help people's health? Or are we going to let it continue to be an anemic part of our healthcare system where most of our clinicians don't want to work? And I think that there are some policy implications that could change this for the better.
Well, I like how we started with optimism. That's good. We'll start with that. Now, in addition to being an expert in this, Bob, you're also a practicing physician. Let's start from that lens. So what are some of the core challenges that practicing primary care physicians face today?
So my practice is a community-based residency program, as you said. So we train residents. I'll start with practice, but then I might move into the education part because that's also a concern for me. On the practice side, just as an example, I have a friend who runs a large PCORI-funded study of sinusitis. And when he came to me for advice on how we might participate in that study, I said, I haven't seen a case of sinusitis in 3 years because all of our urgent care has gone to a walk-in based urgent care clinic. And I am taking care strictly of an aging, multi-morbidity, complex care patient population. I'm not doing the run-of-the-mill kind of primary care that I was even 10 years ago. So it's become a much more difficult patient panel to manage in an inadequate amount of time. I don't have social workers. I don't have community health workers. I don't have the team around me that complexity really needs. And it makes every day a struggle. That doesn't mean I don't love seeing these patients over 10 and 15 and 20 years, but the feeling that I can't actually give them the time they need for the complexity that they're bearing is the real core challenge there. Because I am the place where most people touch the healthcare system, I also have the responsibility for managing over 60 quality measures. And frankly, if I just focused on the care gaps that my patients had, I could do that the entire time they're sitting in front of me and never actually address the reason they came to see me today. So it's created an undue burden for us in managing those. And I'll say on the training side, the concern I have is this newest generation of primary care clinicians in my practice because of the way things have changed, are not getting the experience of taking care of people over their 2 or 3 years that they could in their clinical training. They don't realize what a relationship feels like and taking ownership of a patient feels like. And the narrowing scope that I am being forced into is what they're being trained to, so that they cannot go out and become the comprehensive primary care clinician that I thankfully was trained and was able to become. So I am concerned that if we don't change the model, we are going to wind up with a workforce that is not able to produce the benefits of primary care that we've relied on for so long.
Tell me about technology. We talk a lot lately about technology, things like AI, but what are your thoughts about how that is going to change primary care practice?
Well, this is not unique to healthcare, but I think every time we face difficult choices, we tend to look for a technology solution. And I think that's happening in healthcare right now. That's not to say that technology isn't helpful. So now that I've practiced for 6 months with ambient AI, capturing the conversation and meaning that I can face the patient and talk to them more than type, I won't go back. I will not go back to the way I used to do this because the note taking and the capture of the care that was being provided was just such a burden. So, ambient AI, which 30% of family physicians are using now, thank goodness. We can actually measure that it's actually reducing burnout. Point of care ultrasound, very helpful for being able to do some of the procedures that we want to do in primary care without having to refer those patients on. Amazingly helpful. Where I'm concerned is about the idea that AI could become primary care for people. It is intrinsically without relationship, and that is the problem with AI as the primary care clinician. It may help with making better decisions, with helping patients sort through complexities of their symptoms, but it doesn't fundamentally help guide them in the way that relationships do. And so I think that's a struggle. And then the final thing I'd say is as we bring AI into the diagnostic accuracy or clinical decision making, we already know that we don't get the interoperability of EHRs that we need. It is hard for me to find what happened in their cardiology visit if they're on a different EHR platform. It's hard for me to know what happened at the gastroenterologist or what the pathology of their colonoscopy was. AI is dependent on the data that it can access to help with the decision-making process. And right now, we don't have adequate flow of information to make it as useful and certainly as safe as it should be in primary care. So I just want to give you an array of examples of how I think technology are helping and potentially threatening.
I thought your reference to AI is intrinsically without a relationship is a really sharp take on the fundamental challenge with AI in this context. Tell me about telemedicine, because you didn't talk about that. What role do you see that playing going forward?
Well, I think telemedicine in service to relationship is very valuable. So if a patient can see me in telehealth but not come in to see me in practice, and I can do that, that's fantastic. The efforts by many health plans to shift patients to kind of an urgent telehealth care in lieu of coming to see me or in lieu of reaching out to me by telehealth is a problem because it breaks relationships. I think from that perspective, it is a problem. So I'm not a fan of some of the urgent telehealth solutions that health plans are pushing patients towards. I do think it's a huge benefit for behavioral health and for accessing some of the cognitive specialists who cannot be in rural Montana, for example. So having telehealth in that regard, I think is really important. I really like how Arkansas implemented telehealth, gosh, almost 2 decades ago, where they realized that they only had 4 maternal fetal medicine physicians, all of them in Little Rock, Arkansas, and yet you had people out in rural Arkansas who had complex maternal care needs. And so they set up a telehealth program so that the rural physician got money, got resources to build a telehealth capacity in their practice. And then Medicaid and health plans would pay both the specialist and the primary care physician to be on either end of that telehealth visit so that the rural primary care physician could be the advocate for the patient. They know their history, their values, and could translate for them what the specialist was saying. And the specialist could certainly help upskill the primary care clinician for how you deal with these complex maternal care issues. And they actually rolled that into other specialties like cardiology and nephrology. So that was a really good implementation of telehealth to enable access to subspecialty care that wouldn't be there otherwise. So I think there are good ways to roll telehealth out. There are definitely ways that are not good.
So you touched a little bit on this. I was going to ask you later, but let me get to it now. Apart from telemedicine, telehealth, what are the most promising strategies you see right now in terms of delivering primary care to rural, remote communities?
Well, in the short term, I don't think you can get away from having primary care clinicians and other generalists in the rural communities. On average, whole county health profession shortage areas, most of which will be rural, people there live almost a full year less than people who don't live in areas like that. So we have to get primary care services into those communities. We can't do it just remotely. But I think we have to start doing more of our training in rural areas. We need to move more of our health education into rural areas. First, to provide service through that education process, but second, to help our trainees see that rural areas are a viable place to live and work and be a health professional. So I think we could help solve this problem over the longer run if we start to move our training into those settings.
Let's build on training for a second. Tell me a little bit, what are your thoughts on where we're at with medical education training for primary care? And in particular, I'm also interested in the role that primary care training plays as part of full medical training in large institutions.
I'll start with that. I think helping even our future subspecialists understand the role of primary care and the value of primary care is very important in a setting that is already hierarchical and where people are already told, where students are already told, you shouldn't go into primary care because you're too smart for it, or I've never seen a happy primary care clinician. So we need to expose our trainees of all types to primary care so that they know what it is and how it works. I do think we have to help our trainees experience primary care in training that is robust, that is relationship filled, so that they can walk away and go, wow, that was amazing. And I've had students say that how long have you known this patient? You've known this person for 15 years, and you can look all the way back to where they first had their first baby or they went through that depression, and now you can bring that forward to your conversation today. So trainees, I think you can see that, see primary care as a valuable place to be, and that the ability to help people over time improve their health is such a beautiful thing to be part of. If they don't experience that, they won't choose it because they can't see themselves in that role. I think primary care training for now and into the future is going to be about getting them out of certainly academic health centers. We need to get them out to where most people are seeking healthcare so that they can experience the epidemiology of people coming in with undifferentiated symptoms, so that they can hear how people's community and family context affects their health and their choices, so that they can see that primary care can be a comprehensive set of services, particularly when you have behavioral health integrated or social workers integrated, so that you're really addressing the root causes of people's poor health. So I think we need to move training into that kind of a model so that people are prepared for it, they expect it, and they can see it as a viable path for them.
Tell me a little bit about the role of primary care in engaging with what we call the social determinants of health. Primary care physicians are dealing with patients in their context, and I think primary care physicians are the closest of any physician group, really, to the world around us, the air we breathe, the water we drink, where we live, work, and play. But of course, physicians are physicians. They're trained to deliver care. So how do you navigate that? How do you see the role of primary care physicians in the next 25 years dealing with these social determinants?
Well, we've worked really hard to try and convince CMS that they should be adjusting payments based on social risks so that there's a resource there when a physician identifies a social need. Our practice was part of a large research network that did a study on addressing obesity with patients. And what we found is if you give the physician a resource, in that case, it was Weight Watchers vouchers. It was not a significant resource, but it was something you could give the patient to address their nutrition and obesity needs. And what we found is that when we introduced the voucher, the likelihood of screening and talking about obesity went up 20-fold. So the fact that I has had something that I could do for this patient, for this problem, meant that I was much more likely to address it. And because I felt like I could do something about it. And when the vouchers went away, when the study ended, the likelihood of addressing obesity went right back to baseline. And I think we're in that stage of social determinants right now that when we were reticent to ask about people's housing security or food insecurity because we don't have a resource to give them. But if we gave them the resource, they would do it. And that may mean social workers in your clinic. That may mean community health workers. That may mean, like Massachusetts has done, where you create a bank account that physicians can write prescriptions against. You can suddenly say, I want you to go see this social worker in the community to help you with a housing voucher. I'm writing you a prescription so that you can take it, they get paid, you get the service, and we can close the loop on your needs. In Massachusetts, at least for the programs that participate in that, it has vastly increased the likelihood of asking about and addressing social needs. So I think primary care can play a very significant role in this, again, because it's where most people come for care, but we can't do it if we don't have resources. And so we have to build that in if we want them to be able to do that work.
So that backs up very nicely into the question of innovation. What excites you? What are exciting innovations that you can see coming in primary care that are going to really be changing or at least helping shepherd the evolution of primary care in the coming decades?
I think one of the innovations that I don't know that most people would label an innovation is direct primary care. So can patients elect to pay for a relationship with a physician and the ability to deliver a set of services for them in a more reliable way that can, I think, become a model for what we need other primary care services to look like. I think those are really a nice model for what a health plan or a health system should be designing towards, because that's what patients are voting for with their dollars and their feet. I do think AI and telehealth are going to be important innovations in primary care that we've only touched on. So how does AI help us asynchronously stay in touch with our patients and meet their needs without disrupting the relationships, in fact, strengthening the relationships and helping me be an advisor to a patient when they need me, but helping me sort through their symptoms or their choices for dealing with their healthcare issues better? And likewise, telehealth. How can I not asynchronously, but at the same time in a face-to-face way, but over telemedicine, help people with their care, but in a way that they might not have sought otherwise, or where they might have otherwise gone to urgent care because they couldn't come in to see me in clinic. So I think those are really important innovations.
You've been talking consistently about relationships, about the role of the primary care physician in establishing relationship. How does the primary care physician balance that, let's say, with their role as a navigator, with helping the patient navigate through what is a very complex healthcare system?
So I think that care navigation or care coordination as a function of primary care is incredibly important. And we do a lot of that in the time we have, but we don't have sufficient time to do it well. So I may have a list of specialists that I prefer and that I can reach out to directly to try and get a patient in to see them more urgently. But even I have the luxury of 30-minute visits. It can be really hard in that time to help them navigate. And so it often turns into what we call pajama time, where I'm trying to do coordination off hours outside of clinic to manage those kinds of things. I think we do need more time, and we need staff around us that can help enable that, because we know that care coordination done from primary care often results in better outcomes for patients. And I just think that's an essential function, but time is the most precious resource to enable that.
Let me ask you about two trends which I think are going to shape everything about health, but let's talk about primary care. I want to talk about aging and I want to talk about mental health. Let's start with aging. Tell me about population aging, how it's going to affect primary care, and how are we preparing for what we know is going to happen as the population ages over the next 25 years?
I think that is one of the bigger struggles for primary care, particularly as we take some of the urgent and easy care out of primary care and really put our clinicians into dealing with the most complex and elderly patients. I just saw two of my patients this last Wednesday in clinic, both in their late 80s, both with increasing dementia, cared for by their daughter with an in-home caregiver. All four of us in the same room talking about how these things are being managed. I frankly don't have enough time to deal with both of the patients in that 30 minutes, but what I really need is someone who can carry that work forward. So if I had a community health worker that actually could drop in on our home once a month even to work through, has physical therapy shown up? Have we gotten the safety devices in the house in place for an increasingly demented couple? Does their daughter, as their primary caregiver, have the resources she needs to continue her own work, her own family, and manage this? That is a lot of things that primary care can help coordinate, but I can't manage myself. And that is only becoming harder and harder as the population ages. So the after hours work for that population is incredible, whether it's the durable medical equipment forms that come to me every week for filling out, whether it's the cardiologist who now has a question for me and is sending it to me to the portal. That aging aspect of our patient population is enormous.
Let's talk about mental health, then we'll move to solutions. Tell me about mental health and how are you seeing that changing and how do you anticipate that changing primary care?
So there is increasing push to embed behavioral health within primary care, and that is such a needed service. Mental health affects most of our patients, and primary care delivers most mental health care in this country. But when you find someone who's in distress, to be able to chat with electronically or walk down the hall and talk to my licensed clinical social worker and say, I really need you to just come in, do some initial evaluation and training for this patient. But more importantly, I need your help getting them into a counselor next week and into a consistent counseling relationship. That is something that is so hard for me to do in primary care. And just having that one resource person has made such a difference in my practice. So much so that when our health system decided it wasn't making money, they weren't going to support it, the primary care clinician said, we will collectively support this. So with behavioral health being such a high volume function of primary care, embedding behavioral health is just essential.
Now, you and I both know there's a lot that can be done policy-wise to improve primary care in this country, and some of it is infeasible and politically certainly not viable at the moment. But if we could, what would be your top three priorities? What three policy changes, let's talk about the federal level, should be implemented to make primary care better for all of us?
So at a federal level, I think we need to increase investment in primary care. That can be as many states are moving towards a minimum primary care spend, and that usually ranges from 10 to 15%. And right now in Virginia, Medicaid puts 2.2% into primary care. So it is a meaningful increase in investment in primary care. Part of that is for physician salaries or clinician salaries. Part of that is for building a team around them. There's just a lot of investment that's needed. So that's probably my top priority. My second would be to focus on our training programs. Federally, we spend about $23 to $24 billion on training the physician workforce. Yet the proportion going into primary care and general surgery and psychiatry has just fallen off a cliff over the last 10 years. We need to spend that money more wisely. We need to hold health systems to account for what they're producing in that training pipeline. And we need to move training out into the community. So there's a lot we can do on the training side. And the third thing that I think I would prioritize is fixing our electronic health record system. It is such a source of burden for clinicians, and it's such a safety issue that we cannot access data about our patients at the point of care. It is frankly one of the major burdens for us. So I would focus on solving the electronic health data interoperability problem, because as AI, as I mentioned earlier, comes on board, we will need that data flow to be reliable for helping us take care of people.
Now, the current administration has made some moves towards the data interoperability. So talk us through that and use that as a platform. Talk us about the current administration policy landscape and where all of it you think is going to be landing in terms of primary care.
Well, I think the incentives for electronic health records to stay siloed is extremely strong. It keeps physicians and health systems from moving to different EHR platforms when it's not easy to move data between them. So huge incentive for EHRs to maintain the data silos. The second is the monetization of data is a huge incentive also not to make data more fluid. And both of those things are working very hard against any policies to change it. Our work with the Office of the National Coordinator for Health Information Technology demonstrates that physicians on different EHR platforms can only find medication data that they're able to reconcile for their patient 13% of the time. So it remains a huge burden. I am encouraged in this administration that they're willing to take some steps towards that, but they are bigger steps right now than they're contemplating.
Tell me a little bit about how you think the current policy changes in the public conversation, some on which the administration has acted, some that have been more floated. Let me put it this way. What keeps you up at night?
What keeps me up at night is that, so on the disruptive side, we need some disruption. And in the disruption that has happened most recently around the Relative Uptake Committee for Medicare is important. I don't like that they're taking away a function of regulation for the health professions, but the fact that that process has so long neglected the generalist specialties, including primary care, means it needs disruption. So changing the payment systems for healthcare so that it favors primary care is necessary, and this administration actually gives me some hope that that could happen. On the side that keeps me up at night is that a lot of people are about to lose healthcare coverage or have hard, stark choices about what they pay for in terms of getting healthcare coverage, and that can disrupt relationships in the millions. And it's those relationships we know that matter to people's life expectancy and to the quality of their health. And when those are disrupted, we know it leads to increases in mortality and much worse outcomes downstream. So that's the thing that really keeps me up at night, is changing health coverage in this country.
I keep asking you to look ahead, but let me just ask you to look back for a second. Let's go 25 years back. How do you think primary care today is better, or in which aspects might you think it's not better than it was 25 years ago?
So 25 years ago, the gaps in income between specialties, the things that affect students' choices of choosing primary care or not, they just weren't as strong. And so we were producing a much more robust primary care workforce. People were able to go into independent practice. It was a viable career choice. 25 years later, it is not as viable a career choice, and certainly not for going into independent practice. I think that is a huge problem. It means that only about 10% of our general internists now go into primary care. And even in family medicine, where you don't have subspecialization as much of a choice, we're still seeing a lot of family docs go into hospitalist roles or create niches for themselves around sports medicine when we really need them in the primary care workforce. So it is becoming, while we've called it a crisis for at least 25 years, it is really becoming a crisis. People can't access primary care when they need it.
Okay, well, let's end on a positive note. So what gives you hope in the moment?
What gives me hope in the moment is that there are some really interesting innovations happening, and a lot of them at the state level. California, most recently, is requiring continuity, which is the necessary thing for having relationships in primary care. So health plans now have a requirement that a patient sees their own physician 70% of the time, and that becomes a mandate then for the health systems from the payers. That's going to affect 3 million people in California next year, and that's a really positive thing that they're putting that into policy. Seeing a number of states increase primary care spend through a very blunt policy, but just saying, thou shalt move from 5 to 15% of total healthcare spend is a good sign. It's not how I would choose to do it, but it is going to increase investment in primary care. And the health plans in those states, after they get past complaining about it, often then start to talk about how are we going to do this, and how are we going to create alignment, and how are we going to be ensured that the dollar actually reaches the primary care clinician and isn't soaked by the health system. So that's encouraging to me. I really think states are starting to innovate in ways that they see the federal government not doing. And that gives me real hope, Sandro.
I'm Sandro Galea. I've been talking with Dr. Bob Phillips about the future of primary care in the U.S. Thank you, Bob.
Thank you so much for having me.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com, jamahealthforum.com, or look for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.